Welcome to the deep dive. Today we're tackling a really interesting and potentially game-changing area of stroke management, hyperbaric oxygen therapy,
Right.
HBO
Yep.
therapy.
We sifted through a stack of medical journal articles to bring you the key insights because, let's be honest, understanding stroke and its treatments, it can feel overwhelming.
It really can. There's a lot of information out there.
So our mission in this deep dive is basically to cut through the complexity. We want to extract what you really need to know about how HBO might help, both right after a stroke happens and during that long-term recovery phase.
Exactly. We're not going to get too bogged down in, overly technical jargon, but we do want to give you a solid understanding of the science behind it. Why use HBO for stroke? Where does the research stand right now?
And what the potential implications could be, right?
Precisely. For people affected by stroke, we'll explore how this increased oxygen delivery actually interacts with all the complex things happening in the brain during and after a stroke. Okay, so to get us started, let's just unpack the basics. What exactly is happening in the body when someone has a stroke?
Okay, so at its core, a stroke is a sudden interruption. The brain's blood supply gets cut off, and that leads to neurological problems pretty quickly, too.
An interruption. Okay.
And there are two main types. You've got ischemic stroke, sometimes called cerebral infarction. That's when an artery supplying blood to the brain gets blocked.
Blocks, got it.
Then there's hemorrhagic stroke. That happens when a blood vessel in the brain actually ruptures and bleeds.
Okay, so blockages and bleeds, those are the two fundamental ways it can happen.
That's it.
Makes sense. So focusing on those blockages first, the ischemic strokes, what are the usual suspects there?
Well, ischemic strokes can be caused by a few things. Most commonly, it's a thrombus. That's just a blood clot that forms right there, inside an artery in the brain itself.
Okay, forms on the spot.
Right. Another cause is an embolus. Think of that like a traveling clot. Or it could be other material like fat that forms somewhere else in the body, breaks loose, travels through the bloodstream.
And then gets stuck in the brain.
Exactly. Gets lodged in a brain artery, blocks the flow. Less often you might see ischemic strokes from a sudden spasm of the brain's arteries, or even a blockage of the veins carrying blood away from the brain. That's rarer, though.
Okay. And what about the other side, the ruptures, the hemorrhagic strokes? What's usually behind those?
Hemorrhagic strokes typically happen in one of two main ways. There's intracerebral hemorrhage. That often happens when, long-standing high blood pressure weakens those small arteries deep inside the brain, and eventually they just burst.
Wow. Okay.
The other type is a subarachnoid hemorrhage. That's usually when a weakened blood vessel, maybe an aneurysm, on the surface of the brain ruptures, bleeds into the space around the brain.
Right. Now, I know the World Health Organization, the WHO, they have a specific definition for stroke, don't they?
They do, yes. The WHO defines stroke as, let me get this right, rapidly developing clinical signs of focal or global disturbance of cerebral function, with symptoms lasting 24 hours or longer, or leading to death, with no apparent cause other than of vascular origin.
Okay, that sounds quite precise.
It is. It's pretty comprehensive. It covers the main types, including that subarachnoid hemorrhage, but it specifically excludes things like TIAs, transient ischemic attacks where symptoms clear up quickly, or, events that aren't caused by blood vessel problems.
It's almost hard to wrap your head around the sheer scale of stroke worldwide. I mean, what kind of impact are we talking about globally?
Oh, the numbers are. They're really quite staggering. The WHO estimates something like 15 million people across the globe have a stroke each year.
15 million. Wow.
Yeah. And tragically, about 5 million of those are fatal. Another 5 million result in permanent disability.
That's devastating.
It really is. It makes stroke a leading cause of both death and long-term disability worldwide. In industrialized nations, Western Europe, the U.S., it's a major reason people end up in hospital. Accounts for maybe 10% of all deaths.
And even for those who survive, the effects can be absolutely life-altering, can't they?
Absolutely. I mean, just in the U.S., there are millions of stroke survivors. Hundreds of thousands leave hospitals every year after a stroke. But, and this is the tough part, estimates suggest only a small fraction, maybe 10%, can return to work without some level of disability.
Maybe 10%.
Yeah. A large number face moderate to severe disabilities, and, some need long-term care in institutions. And unfortunately, the rate of stroke is actually increasing in many parts of the world, places like India and China, too.
So who is most at risk? Are there particular things that make someone more likely to have a stroke?
Yeah, we know quite a few risk factors now, and they've fallen into different categories. Older age is a big one, naturally. Lifestyle choices play a huge role. Things like Excessive alcohol, not being active enough, a diet really high in salt, smoking, all big contributors.
The usual suspects for many health issues, really.
Pretty much. Then there are cardiovascular factors, heart disease, an irregular heartbeat called atrial fibrillation, AFib, high blood pressure, having had a previous heart attack. All increase risk.
Okay.
Endocrine disorders, too, like diabetes, thyroid problems, they're linked.
Mm-hmm.
Certain genetic predispositions, blood clotting disorders, even sleep issues like sleep apnea.
Sleep apnea. Interesting.
Yeah. And it's also worth noting, statistically, strokes are a bit more common in men and also in Black Americans.
It sounds like a really complex web of factors.
Yeah.
Now, thinking about what's actually going on in the blood vessels of the brain that leads to a stroke, beyond these risks, what's the underlying process?
The general term we use is cerebrovascular disease.
Yeah.
It basically just means any problem in the brain that comes from abnormalities in its blood vessels. And these problems can involve, damage to the actual wall of the blood vessel, a blockage inside the vessel, the lumen, by a clot or fatty stuff like plaque.
Atherosclerosis?
Exactly, atherosclerosis. Or it could be a rupture of the vessel, changes in how easily things pass through the vessel, wall permeability, and even issues with the blood itself, like if it gets too thick, too viscous.
So when we talk about the direct causes of a stroke, how do they link back to those risk factors? Is it just the same list?
Well, the direct causes often overlap strongly with the risk factors, but the link is more immediate, more causal, you could say.
All right.
So yes, atherosclerosis, that hardening and narrowing of arteries, is a major direct cause of blockages.
Right.
But blockages can also happen because of infections or injuries to the head and neck. Even some rare cases linked to things like chiropractic neck adjustments have been reported.
Really?
Yeah, it's rare but documented. Also, congenital abnormalities being born with vessel issues, blood clotting disorders, drug use, particularly stimulants. An embolus that travels from elsewhere, as we mentioned, blood disorders, sometimes complications from medical procedures, we call that iatrogenic. Also, inflammatory diseases that affect blood vessels, and even rarer conditions like moyamoya disease. It's quite a list.
It really is a surprisingly long list of potential triggers. And within those ischemic strokes, the blockages, are there different sort of subcategories based on what's actually happening?
Yes. We can break down the causes of ischemic stroke a bit further.
Okay.
Interestingly, in a pretty big chunk of cases, maybe around 40%, the exact cause actually stays uncertain, even after doctors investigate thoroughly.
40%, that's quite high.
It is. Among the known causes, a blockage in one of the big arteries in the brain, a large artery occlusion accounts for some, having problems in multiple connected arteries. Tandem arterial pathology accounts for others. Then you have lacunar strokes. Yeah, those involve the really tiny, penetrating blood vessels deep inside the brain. Yeah, they're quite common. And then in about, say, 1 out of every 5 ischemic strokes, the cause is traced back to the heart, a blood clot that formed in the heart, an embolus that then traveled up to the brain.
Okay, so the blood supply gets cut off. What happens next, like on a cellular level in the brain? Why is that interruption so damaging so incredibly quickly?
Right. The brain is just unbelievably metabolically active. It constantly needs oxygen and glucose delivered by the blood.
Non-stop.
No reserves. Exactly. If that blood flow stops completely, neurometabolism gets disrupted within seconds. Seconds. Electrical activity in the brain stops within a couple of minutes. And actual physical damage, cell death, can begin in as little as 5 minutes.
5 minutes? That's terrifyingly fast.
It is. Brain tissue starved of oxygen undergoes necrosis. We call it infarction. Essentially, the tissue dies. These dead areas, the infarcts, can look pale if there isn't much blood leaked into them.
Right.
Or they can be hemorrhagic if some small damaged blood vessels bleed into the dead tissue. But here's the critical point. For a few hours right after the stroke starts, some of these changes might be reversible. That's why those first 3 hours after an acute ischemic stroke are so often called the therapeutic window.
That 3-hour window, it sounds absolutely crucial. What are the stages of damage that the brain tissue goes through after this blood flow stops? Like, how does it physically change over time?
Looking at it morphologically, how it appears, a cerebral infarct typically evolves through 3 main stages. First is what's called coagulation necrosis. The tissue sort of becomes firm, solidifies.
Okay.
Then liquefaction necrosis happens. The damaged tissue starts to break down, turns into a liquidy substance.
Liquefies.
Yeah. And finally, cavitation. The liquid eventually gets absorbed by the body, leaving behind a cavity, basically a hole, in the brain tissue where the infarct was.
And within that area of damage, are all the brain cells affected in the same way, or is it more complex?
No, it's definitely more complex. Within an infarct, you can actually distinguish three zones based on the histological changes, what you see under a microscope. There's the central zone, the core. That's where the blood flow and oxygen deprivation were most severe. That's where you see the most significant neuronal death,
The dead center.
pretty much.
Yeah.
Surrounding this core is the reactive zone. Here you've got ongoing neuronal death, but also inflammation, immune cells moving in, and angiogenesis, the formation of new blood vessels trying to compensate.
Okay, a zone of reaction and attempted repair.
Kind of. And then further out, you have the marginal zone. Here, the neurons might be shrunken, and astrocytes, those are important support cells in the brain, they become swollen and proliferate, increase in number and size.
This brings us to something really important. I've heard about the penumbra. I understand this is a key target for treatments. Can you explain what's happening there?
Absolutely. The penumbra is crucial. It's the region of brain tissue that surrounds that central core of infarction, the dead zone. Now, the neurons in the penumbra aren't functioning normally. They're sometimes described as dormant or idling, and this is the vital part, they are still structurally intact. They're alive, just stunned. And potentially salvageable.
Salvageable, so they could recover.
Potentially, yes. The most critical factor for these penumbral cells is oxygen availability. Even if the blood flow is reduced, if enough oxygen can still get to them, they might survive and eventually recover function.
Ah, I see.
This penumbra is why the initial symptoms of a stroke don't always perfectly predict the final outcome. There's this window of opportunity, this area of tissue we can potentially rescue.
So it really is a race against time to save the penumbra. What are the sort of biochemical dominoes that start falling in the brain right after a stroke that cause all this damage?
Right. When blood flow is cut off, it sets off this really complex, damaging cascade of biochemical events.
Yeah.
One of the key initial players is glutamate.
The neurotransmitter.
Exactly. Normally, it excites brain cells, helps them communicate, but during a stroke, way too much glutamate gets released. It overstimulates the neurons, leading to a massive influx of calcium ions into the cells.
Calcium overload. Is that bad?
Very bad in this context. This calcium overload then triggers a whole host of damaging downstream processes. It activates enzymes that literally break down the cell's structures, its proteins, its membranes, its DNA. And it also leads to the production of harmful molecules called oxygen-free radicals.
Oxygen-free radicals, we hear a lot about those in general health. What specific damage do they do during a stroke?
Free radicals are nasty customers. They're highly reactive molecules because they have unpaired electrons. They wreak havoc by attacking and oxidizing vital cell components, proteins, DNA. They can further mess up calcium levels inside cells, activate more destructive enzymes, and damage the fatty membranes that enclose cells, causing them to leak.
Sounds like a multi-pronged attack.
It is. And this damage can also trigger inflammation, making things worse. Now, our bodies do have natural defenses against free radicals, antioxidant enzymes, vitamins like E and C. But during a major event like a stroke, these defenses can just get completely overwhelmed by the sheer flood of free radicals being produced.
Right. And interestingly, when we think about HBO therapy, adding more oxygen, wouldn't that risk creating more free radicals? Is that a concern?
That's a really logical question, and it is a theoretical concern. Giving more oxygen could potentially increase free radical production. However, the current evidence from studies actually looking at HBO in stroke patients doesn't strongly suggest that it causes harmful levels of oxidative stress, at least not at the pressures typically used.
Okay, that's reassuring.
Yeah, it seems the potential benefits of getting that desperately needed oxygen to the penumbra might outweigh the theoretical risks of slightly increased free radical activity in this specific situation.
You also mentioned something called reperfusion injury earlier. If the main goal is to restore blood flow, how can doing that sometimes cause more damage? That seems counterintuitive.
It does seem paradoxical, doesn't it? But reperfusion, while absolutely necessary for potentially saving tissue, can indeed lead to further injury. It happens through several mechanisms.
Like what?
Well, one is a sudden disruption of calcium balance again when blood flow returns. Another is the generation of even more free radicals when oxygen suddenly floods back into tissue that's already damaged and primed for it.
Oh, okay.
There can also be damage caused by white blood cells, inflammatory cells, that rush into the area once blood flow is restored. And even some evidence suggests a sudden spike in local cholesterol levels can contribute. So while restoring blood flow is vital, the way it happens and the state of the tissue can lead to this secondary wave of injury.
Wow. It sounds like there's just a whole network of different molecular pathways getting thrown out of whack during a stroke.
Absolutely. Research is constantly uncovering more about the intricate molecular mechanisms involved. It includes things like changes in gene expression, which genes get turned on or off,
Okay.
the production of heat shock proteins, which can actually be protective in some ways, the release of signaling molecules called cytokines and adhesion molecules that drive inflammation, processes involving DNA damage and the cell's attempts to repair it, the role of neurotrophic factors, which normally support neuron survival, and the activation of specific enzymes like PARP, which is involved in cell death pathways.
Can you give an example?
Sure. For instance, certain genes like CFOs and CJUN get activated very early after brain injury. Proteins like HSP70, one of those heat shock proteins, are thought to have a protective role.
Hmm.
On the flip side, inflammatory cytokines like TNF-alpha definitely contribute to the damaging processes. And neurotrophic factors like BFGF might help promote survival or repair. It's incredibly complex.
Given all this complexity, how do doctors actually classify ischemic strokes? How do they make sense of the different ways it can present in patients?
Yeah, a practical way to classify ischemic stroke looks at several things together. It considers the initial clinical features, the symptoms the patient presents with. What the brain imaging, like CT or MRI, shows, where's the damage, how big is it? The underlying vascular pathology, what's wrong with the blood vessels, the clinical course, how the stroke evolves over time, does it get better, worse, or stay the same? And, of course, the major risk factors the patient has.
So you piece it all together.
Exactly. For example, a patient might come in with weakness on one side, initial feature. A ZT scan shows a small infarct deep in the brain, imaging. Maybe angiography shows narrowing of a carotid artery, vascular pathology. Their symptoms improve slightly over a few weeks, clinical course, and they have a history of high blood pressure, risk factor. Putting all that together gives a much more complete picture of that specific patient's stroke, which helps guide treatment and predict outcomes.
Okay, that makes sense. And what about the recovery process? After the initial event, what are the key factors that influence how well someone might recover function?
Recovery is also really complex and varies hugely between individuals. Several factors play a role. Having a good collateral blood supply, basically, alternative routes for blood to reach brain areas can make a big difference.
Like natural bypasses.
Sort of, yeah. The regression of cerebral edema, that brain swelling, is also important as it reduces pressure. The survival of those penumbra cells we talked about is obviously key. Then there's the brain's amazing ability to reorganize itself.
Neuroplasticity.
Exactly, neuroplasticity or cortical reorganization.
Yeah.
The brain finding new ways to do things. And finally, the recovery of the brain's energy metabolism, getting those cells functioning efficiently again, is also crucial.
You mentioned neuroplasticity, the brain rewiring itself. How does that actually work in stroke recovery? What's happening?
It involves a couple of main mechanisms. One is the unmasking of neural pathways that were already there but maybe weren't being used much. The brain kind of redirects traffic. The other is synaptic sprouting neurons, actually growing new connections, new synapses to try and bypass the damaged area or take over lost functions.
So the brain is actively trying to compensate.
Yes, absolutely. We tend to see the most significant recovery of motor skills, like movement, in the first few months after a stroke. But functional recovery can definitely continue, sometimes for a year or even longer. And interestingly, if someone shows some improvement relatively early, say within the first 48 hours, that often correlates with a better long-term outcome.
Are there any immediate neurological complications that doctors watch out for right after someone has an ischemic stroke?
Yes. Unfortunately, there can be several acute issues. These can include a worsening of the initial neurological problems, the development of significant brain swelling, which can be dangerous because it increases pressure inside the skull,
Right.
the infarct getting bigger, or even a new stroke occurring, bleeding into the area that was already damaged by the lack of blood flow, hemorrhagic transformation, and seizures. Sadly, if someone's condition deteriorates early on after a stroke, it's often linked to a less favorable outcome overall.
And thinking longer term, after that acute phase is over, what kind of lasting challenges might stroke survivors commonly face in the chronic stage?
Yeah, in the chronic post-stroke stage, various neuropsychological problems are quite common. We see things like persistent weakness or paralysis, of course. Epilepsy can develop. And conditions like spasticity.
Spasticity, what is that exactly?
Spasticity is basically an increased muscle stiffness or tightness that gets worse the faster you try to move a limb. It's velocity dependent. And it can really interfere with movement and rehabilitation efforts.
Okay.
Some people also experience chronic pain, central post-stroke pain syndrome. Memory problems are common, difficulties with thinking, planning, understanding, cognitive deficits. And this can sometimes progress to dementia, specifically vascular dementia, which is often caused by the cumulative effect of reduced blood flow or multiple small strokes.
Right.
Depression is also very common after stroke, post-stroke depression. And
Okay.
a whole range of other emotional and behavioral changes can occur too.
So, getting an accurate diagnosis quickly is obviously vital. How do doctors figure out if someone has actually had a stroke versus something else?
Well, the initial suspicion usually comes from the patient's symptoms and the findings on a neurological examination. Sudden weakness, speech problems, vision changes.
The classic signs.
Exactly. But that clinical suspicion needs confirmation. That involves laboratory tests to rule out other causes, and most importantly, brain imaging. CT scans are often done first because they're quick and good at showing bleeds. MRI scans provide more detail about ischemic damage.
Okay.
In some centers, CT scans might be used too, especially to look at blood flow patterns in the brain. And it's also really important to investigate the heart, looking for potential sources of clots, like atrial fibrillation.
And what about stroke scales? We often hear about those being used. What's their purpose?
Stroke scales are essentially standardized tools. Doctors and researchers use them to quantify the neurological deficits, how severe the problems are, and to assess the patient's overall level of disability and function.
Okay, like putting a number on it.
Kind of, yeah. Common scales include the Barthel Index, which looks at ability to perform basic daily activities like dressing and eating. The Rankin scale gives an overall grade of disability, from no symptoms to severe disability. The NIH stroke scale is a very detailed, standardized neurological exam, often used in clinical trials. There's also the Unified Neurological Stroke Scale, the Canadian Neurological Scale. Different tools for slightly different purposes.
And they help track progress, too.
Exactly. They're really helpful for assessing the initial severity, tracking changes in the patient's condition over time, are they getting better or worse, and also for evaluating how effective different treatments are in research studies.
Okay, we've covered a lot of ground on really understanding stroke itself. Now let's shift gears and talk about how stroke is typically managed, both right when it happens and then in the longer recovery period.
Right. And the approach really does differ quite a bit between that immediate acute phase and the later chronic post-stroke stage. Well, in the acute phase, the absolute main goal is damage control, trying to limit how much irreversible damage occurs in the brain. And as we've discussed, that's a huge challenge because of that very limited therapeutic window. Time is brain, as they say.
Right.
In the chronic stage, the focus shifts much more towards rehabilitation, trying to help the patient regain as much lost function as possible and manage any long-term complications.
Okay. So focusing on the acute phase first, what are the primary objectives of treatment right after a stroke hits?
The main objectives are, well, firstly, trying to reduce the risk of death. Secondly, restoring normal blood flow to the brain as quickly and safely as possible. That might involve medications to break up clots or sometimes surgical procedures to remove blockages. Thirdly, neuroprotection, trying to protect those brain cells, especially in the penumbra, from further damage caused by the lack of oxygen. Fourth, providing supportive medical care managing blood pressure, blood sugar, hydration, preventing complications like pneumonia. Fifth, preventing the stroke from getting worse or happening again soon. And finally, starting rehabilitation as early as it's safe and feasible. Ideally, all this should begin within the first hour of symptoms starting.
Within the first hour, that's incredibly fast. Thrombolytic therapy, like TPA, the clot buster drug, is probably the best known treatment for acute ischemic stroke. What other methods are used or being investigated right now?
Yes, TPA is crucial if given within that window, usually 3 to 4.5 hours for eligible patients. Besides thrombolytics, immediate management can involve anticoagulant or antiplatelet drugs to prevent more clots forming. Careful management of other medical issues is vital: height, blood pressure, heart problems, infections. And in some cases, surgical interventions might be needed, like mechanically removing a large clot, thrombectomy, or rarely surgery to relieve pressure if there's massive brain swelling. But, there are still many unanswered questions and limitations to current treatments. So researchers are actively investigating other potential therapies. These include those neuroprotective drugs we mentioned, aiming to shield neurons, hyperbaric oxygen therapy, which is our focus today,
Hmm?
induced hypothermia, cooling the brain down slightly, and various combinations of these approaches.
Right. What about those neuroprotective agents? What kinds are being looked at?
There's a whole range under development. Things like adenosine analogs mimicking a natural brain chemical,
Mm-hmm.
anti-inflammatory agents, Apoptosis inhibitors, drugs designed to block the program's cell death pathway,
Mm.
calcium channel blockers, free radical scavengers, glutamate antagonists to block that excitotoxicity. Lots of different angles being explored.
Neuroprotection sounds like such a critical goal shielding the brain. But you mentioned earlier there's also a limited time window for that too.
Yes, unfortunately, that's been a major hurdle. Many neuroprotective agents have shown great promise in lab studies and animal models, but they haven't translated very well into successful human clinical trials.
Why is that?
A key reason is often the difficulty in getting the drug to the patient, across the blood-brain barrier and into the brain tissue quickly enough within those critical first few hours after the stroke begins. Ideally, you'd want to give a neuroprotective agent as soon as possible, maybe even before or at the same time as a reperfusion therapy, like TPA, if the patient is getting it. The window is just very tight.
What about some of the more sort of futuristic potential treatments you touched on? Oxygen carriers, cell therapy, gene therapy. Where are we with those?
Those are definitely exciting frontiers in stroke research, but still largely experimental for stroke right now. Oxygen carriers, things like hemoglobin-based solutions or perfluorocarbons, are being explored as a way to just boost the amount of oxygen getting delivered to that ischemic tissue, even if blood flow is poor.
Okay.
Cell therapy, often using various types of stem cells, holds promise for either repairing the damaged tissue directly, or maybe more likely, releasing beneficial growth factors and molecules that reduce inflammation and help the brain's own recovery processes.
And gene therapy.
Gene therapy involves introducing genetic material into target cells to try and alter the disease process. For stroke, strategies might include introducing genes that help with glucose transport into cells, or genes that promote the growth of new blood vessels, angiogenesis, to improve collateral flow. These are complex approaches, still needing a lot more research before they can become clinical realities.
It seems logical to think about using different treatments together, doesn't it? Are researchers looking into combining therapies?
Absolutely. Combination therapy is a very active area of investigation. The idea is that attacking the problem from multiple angles might be more effective than any single treatment alone. So combining thrombolytics like TPA with neuroprotective agents or perhaps with HBO makes a lot of sense.
How might they work together?
Well, for instance, a neuroprotective drug might help counteract some of that reperfusion injury that can sometimes occur when you restore blood flow with TPA. Or HBO might help keep the penumbra alive longer, extending the time window for other treatments to work. The synergy is the goal.
Now, let's shift focus to the chronic post-stroke stage, weeks, months, years later. You mentioned the main emphasis becomes rehabilitation. What does typical management look like then?
Yeah, unfortunately, compared to all the research and focus on the acute phase, there are often fewer specific medical treatments targeting brain recovery itself in the chronic stage. Management primarily revolves around rehabilitation, physical therapy, occupational therapy, speech therapy to help patients maximize their functional independence.
Okay.
For specific problems like spasticity, conventional treatments include ongoing physical therapy and stretching, medications like baclofen or tizanidine to relax muscles, sometimes injections of botulinum toxin like Botox into spastic muscles, and in some severe cases, surgical procedures might be considered.
And what about trying to improve motor recovery, like strength and coordination?
Again, ongoing physical and occupational therapy are the mainstays. Some drug therapies have been tried experimentally to try and boost motor recovery, things like amphetamines, levodopa. But honestly, the evidence supporting their effectiveness isn't very strong or consistent. Neuroregeneration strategies and surgical procedures are still largely research topics for motor recovery.
You also mentioned managing vascular dementia and post-stroke depression in the chronic phase. How are those typically handled?
For vascular dementia, the main strategy is really prevention of further vascular damage. That means aggressive management of all those risk factors we talked about: blood pressure, cholesterol, diabetes, smoking cessation. There are some medications approved for Alzheimer's dementia that are sometimes tried for vascular dementia, like cholinesterase inhibitors or memantine, but the evidence for significant benefit isn't robust. For post-stroke depression, which is very common and impacts recovery, standard antidepressant medications are often effective and are the primary treatment, along with psychological support or therapy. And interestingly, as we'll get into, some studies have suggested HBO therapy might also have a role in managing post-stroke depression, sometimes even used alongside antidepressants.
Okay, this brings us right to the heart of our deep dive today. The potential role of hyperbaric oxygen, HBO, in managing stroke. Let's start with the basic science. Why would putting someone in a high-pressure oxygen chamber actually help when the brain is starved of oxygen? What's the rationale?
The core scientific basis is actually pretty straightforward. When you breathe pure oxygen under increased atmospheric pressure, that's what happens in an HBO chamber, it dramatically increases the amount of oxygen that dissolves directly into the liquid part of your blood, the plasma.
More than just what the red blood cells carry.
Way more. Normally, almost all oxygen is carried by hemoglobin and red blood cells. HBO significantly boosts the oxygen carried dissolved in the plasma. This superoxygenated plasma can then travel through the bloodstream and diffuse into tissues, including the brain.
So it can reach areas where blood flow is poor.
Exactly. It helps counteract the hypoxia, the lack of oxygen, in those ischemic brain tissues. This extra dissolved oxygen can potentially reach areas where red blood cells might be struggling to get through due to narrowed vessels or blockages. It basically provides an alternative oxygen delivery route.
Okay, that makes sense. Are there other potential benefits too?
Yes, several others are proposed. HBO might improve microcirculation, the flow in the tiniest blood vessels possibly by making the blood less viscous, reducing platelet aggregation, stickiness, and making red blood cells more flexible. It's also thought to help reduce cerebral edema, that brain swelling. It does this partly by causing vasoconstriction, a slight narrowing of blood vessels in normally oxygenated areas, which can shift blood flow towards the ischemic areas and reduce fluid leakage across the damaged blood-brain barrier. Okay. Additionally, some evidence suggests HBO might directly reduce the swelling of individual neurons and, crucially, improve oxygen levels specifically within the penumbra, that salvageable zone, helping those idling neurons survive and potentially recover function.
And I think you mentioned something about stem cells earlier.
Yes, that's a newer area of research, mostly from animal models so far. But some studies suggest HBO might help mobilize stem cells from the bone marrow, which could then travel to the injured brain. It might also stimulate the release of beneficial growth factors and potentially promote neurogenesis, the creation of new nerve cells, and gliogenesis, new support cells. So it's potentially tackling the problem from multiple angles: immediate oxygen supply, reducing swelling, improving blood flow, and maybe even promoting repair mechanisms.
So it's really trying to overcome that oxygen deficit through several different mechanisms. You also touched on the free radical issue earlier. Just to recap, how does HBO fit with that concern in stroke?
Right. As we said, the theoretical concern exists. More oxygen could mean more free radicals. But in the context of stroke, patients treated with HBO at the commonly used therapeutic pressures, usually 1.5 to 2.5 times normal atmospheric pressure, the clinical evidence suggesting this causes significant harmful oxidative stress is not convincing.
Okay.
In fact, some experimental work has even shown HBO didn't worsen brain injury and didn't necessarily lead to a big spike in harmful free radicals when used for experimental stroke. It seems the overwhelming need for oxygen in the ischemic brain might outweigh this theoretical risk, provided the HBO pressure and duration are appropriate.
We've talked about the why, the rationale. Now, what about the does it work? What does the research in animals tell us about HBO's effectiveness for stroke?
Animal studies have generally been quite encouraging, though not entirely uniform in their findings. Numerous studies in various animal models, dogs, gerbils, rats, cats, using different ways to induce stroke or oxygen deprivation, have shown positive effects from HBO.
What kind of positive effects?
Things like improved neurological recovery scores, better cerebral blood flow measurements, reduced levels of lactic acid, which builds up without oxygen, smaller infarct sizes on brain imaging, improved survival rates, reduced brain edema, and even evidence of increased neurogenesis, new neuron growth in some studies.
Okay, that sounds promising.
Some studies have also looked at combining HBO with other treatments. For example, one showed that the drug memantine, which affects glutamate receptors, might enhance the benefits seen with HBO alone in a rat model.
But you said the findings weren't entirely uniform.
Right. It's important to note that the timing of HBO administration after the stroke seems critical in animal models. Generally, earlier treatment tends to be more effective. The pressure used also matters. Some studies found benefits at certain pressures, but not others, or even potential harm at very high pressures, or if delayed too long.
So timing and dose are key.
Absolutely. However, a systematic review that pooled data from many experimental studies did conclude that, overall, HBO therapy significantly reduced infarct size and improved neurological function in these animal models of stroke. So the preclinical evidence is generally supportive.
And there's also this concept, you mentioned HBO preconditioning. What's that about?
Right. HBO preconditioning, or HBO-PC. This involves giving an animal short, repeated exposures to HBO before inducing a stroke. The idea is that these mild, intermittent oxygen stresses trigger protective mechanisms within the brain cells, making them more resilient to a subsequent, much more severe ischemic insult. It's like training the brain to withstand low oxygen better.
How might that work?
Experimental findings suggest HPOPC might work by increasing levels of protective proteins like HIF1, hypoxia-inducible factor 1 alpha, activating antioxidant defense pathways, like the SIRT1-NRF2 pathway, and potentially reducing inflammatory responses and pathways involved in cell death, like the RSTRPNLRP3 pathway. Some studies have even shown benefits of HPOPC in animal models of hemorrhagic stroke, reducing bleeding and inflammation. It's a fascinating concept of building ischemic tolerance.
Okay, so the animal data seems largely positive, especially regarding timing and maybe preconditioning. What about studies in humans? What does the clinical evidence actually say about using HBO for stroke patients?
This is where things get a bit more complicated and, frankly, controversial. There have been quite a few uncontrolled clinical studies over the years involving many patients. Many of these reported pretty high rates of improvement with HBO, sometimes seemingly better than expected with standard care alone, in both acute and chronic stroke patients.
But uncontrolled means no comparison group, right?
Exactly. So, while it's suggestive, you can't definitively say the improvement was solely due to the HPO. Natural recovery happens, rehabilitation helps. You need controlled trials for stronger evidence.
Okay, so what about the controlled trials?
There have been relatively few well-designed randomized controlled trials, RCTs, of HBO for acute ischemic stroke, and the results have been mixed. Some early, smaller trials showed maybe a slight trend towards benefit or no significant difference. One controversial trial published in 2003 by Rosiniak and colleagues actually suggested potential harm with HBO at 2.5 ATA started relatively late. However, the methodology of that study, particularly the timing and pressure used, has been debated.
So conflicting results in the acute phase trials.
Largely, yes, and the overall quality of evidence has been limited. A subsequent analysis suggested that the total dose of HBO might be important, not just single sessions. However, more recently, a well-conducted prospective RCT by Afradi and colleagues in 2013 focused on patients in the chronic stage, months to years after their stroke.
And what did that find?
That study did show significant neurological improvements in motor function and other areas with HBO therapy compared to a control group, even in patients who were considered to have plateaued in their recovery. This suggests the brain might retain plasticity and the potential to improve with interventions like HBO much later than previously thought.
That's a potentially important finding for chronic stroke.
It is. However, when you look at systematic reviews like the Cochrane Database Review, which pools data from all available RCTs, their conclusion has generally been that there's currently insufficient high-quality evidence to confirm or refute a clinically important benefit of HBO for stroke patients, either acute or chronic. They emphasize the need for more, larger, better-designed trials.
So the jury is still out, officially speaking.
Pretty much, especially for acute stroke. They don't rule out a benefit, but the evidence isn't strong enough yet for firm recommendations. There are some ongoing trials, for instance in Canada, that might help clarify things in the future.
You mentioned some of the difficulties in translating animal results to humans. Can you elaborate on why that's been so challenging for HBO in stroke?
Yeah, there are several key reasons. First, human stroke is just much more heterogeneous diverse than the strokes typically induced in lab animals. Humans have strokes in different locations of different sizes, caused by different underlying vascular problems, and often have other health issues, comorbidities, that animals in studies don't have.
Makes sense. Animal models are simplified.
Right. Second, the timing issue is critical. In animal studies, HBO is often started very quickly after the stroke. In human trials, especially for acute stroke, there were often delays in getting patients diagnosed, transported, and into a hyperbaric chamber, potentially missing that optimal therapeutic window seen in animals.
Logistical challenges.
Huge logistical challenges. Third, the specific HBO protocols, the pressure used, the ATA, the duration of sessions, the number and frequency of treatments have varied a lot between different clinical studies, making it hard to compare results or know what the optimal dose might be.
Lack of standardization.
Exactly. And finally, effectively blinding studies with HBO is really difficult. It's hard to give a sham hyperbaric treatment without the patient or the researchers knowing. This lack of blinding can introduce bias.
So what's needed for future studies?
To get more definitive answers, future trials really need careful patient selection, perhaps using advanced neuroimaging like MRI to identify patients with salvageable penumbra who are most likely to benefit. They need standardized, optimized HBO protocols based on preclinical data and maybe pilot studies. Finding better ways to blind the studies is important, and focusing on clinically meaningful outcomes over longer follow-up periods.
Okay. Let's zoom in on one specific study you mentioned earlier, the Klausenbach study. This looked at HBO as a supplement to rehabilitation in chronic stroke patients. Can you tell us more about that one?
Yes, the Klausenbach study, which was actually conducted by Dr. Jain, one of the authors of our main source material, focused specifically on motor deficits and spasticity in chronic stroke patients already undergoing rehab.
Okay, what did they do?
They took 50 patients who had persistent weakness or paralysis, hemiparesis or hemiplegia, long after their stroke. They assessed them carefully before, during, and after a course of HBO therapy. The HBO protocol was typically daily sessions at a relatively low-pressure 1.5 ATA for 45 minutes. Crucially, they often combined the HBO session with simultaneous physical therapy performed inside the chamber.
Physical therapy in the chamber. Interesting.
Yeah. The main things they measured were objective hand grip strength using a dynamometer and clinical assessments of muscle power and spasticity levels.
And what were the results?
The study reported quite striking results. They stated that 100% every single patient showed a measurable improvement in hand grip strength on their affected side during the HBO treatment sessions. They also observed a significant reduction in spasticity in those patients who had it.
100%. That sounds remarkable. Was it lasting?
Well, they noted that the initial improvement seen during a single session seemed to be temporary, wearing off afterwards. However, they found that with repeated daily sessions, typically over about 6 weeks, these improvements could accumulate and become more sustained, more long-lasting.
Okay, a cumulative effect.
Exactly. And they specifically highlighted that when physical therapy was done concurrently during the HBO session, the relief from spasticity seemed to last longer after the session compared to HBO alone.
What did the researchers conclude from this?
They concluded that HBO at this 1.5 ATA pressure was safe and well tolerated in these chronic stroke patients. They proposed it could be a valuable addition, an adjunct, to conventional rehabilitation programs, helping to improve motor power and relieve spasticity. They even suggested it might be superior to some surgical procedures aimed at improving blood flow, like ECC bypass in certain cases, and that early HBO might even prevent spasticity from developing.
Those are some strong claims based on that study. What were the main concluding remarks from the researchers themselves in that paper?
They really emphasized that key finding. Every single patient with existing neurological deficits showed a measurable increase in hand grip power while breathing oxygen at 1.5 ATA pressure. They reiterated that while initially transient, the effect became more sustained with repetition. They did acknowledge the degree of benefit likely depended on the severity of the initial brain damage.
Okay.
They strongly highlighted the significant reduction in muscle stiffness, the spasticity relief, especially when combined with physiotherapy in the chamber, and they put forward the idea that starting HBO early might be prophylactic against spasticity. They stressed the safety profile at 1.5 ATA and essentially recommended that HBO should be considered as a routine component of stroke patient management based on their findings.
So pulling everything together now from all the sources we've looked at, the basic science, the animal studies, the mixed clinical trials, the Klausenbach study, what are the overall conclusions we can draw about the effects of HBO in stroke patients?
Okay, synthesizing it all. The sources provide a clear, logical rationale for why HBO might work in stroke, mainly by boosting oxygen delivery to ischemic brain tissue and potentially improving microcirculation and reducing edema.
Right. The scientific basis seems sound.
Yes. The sources also acknowledge the limitations of current conventional stroke treatments, especially for neuroprotection and promoting recovery in the chronic phase. The animal studies and many of the uncontrolled human studies are described as generally encouraging, showing potential benefits.
But with caveats.
With caveats, yes, particularly regarding translation to humans and the need for controlled data. The Klausenbach study specifically provides evidence suggesting that combining HBO, especially at 1.5 ATA, with physical therapy can yield positive results in the chronic stage, particularly for improving motor function and reducing spasticity. The sources suggest a plausible mechanism for spasticity relief through HBO. They also touch on HBO potentially having a role in selecting patients for certain surgical procedures. However, they consistently point out that the evidence for HBO's effectiveness in the acute phase of stroke from controlled trials is still lacking or inconclusive.
So more work needed there.
Definitely. Future studies in acute stroke need careful design, particularly regarding patient selection, maybe using imaging like DWI or PWI, standardization of HBO parameters, timing, pressure, duration, and robust blinding methods. Importantly, though, the sources generally emphasize that HBO, when used at appropriate therapeutic pressures like 1.5 to 2.0 ATA, appears to be safe for stroke patients.
Looking ahead then, what are some of the future prospects? Where does research need to go, and what's the potential outlook for HBO in stroke care?
Well, the big need is for those rigorous, well-designed, large-scale randomized controlled trials, particularly focusing on the acute phase, maybe testing HBO within that critical 3 to 5 hour window, perhaps even earlier if feasible.
The golden hours.
Exactly. The fact that the FDA has approved HBO for another condition involving acute vascular occlusion, central retinal artery occlusion, basically a stroke in the eye, is seen by some as a positive sign, suggesting regulatory acceptance of the underlying principle for certain conditions.
That's interesting.
There's also continued interest in exploring HBO as part of combination therapies.
Yeah.
Could it enhance the effectiveness or extend the therapeutic window for thrombolytics like TPA or for neuroprotective drugs currently under development? That synergy potential is still very much on the table.
Okay. So to try and summarize the key takeaway from our deep dive into these sources today, it seems HBO therapy shows real promise, definite potential as a tool in stroke management, particularly maybe in the longer-term recovery phase and as an adjunct to rehabilitation based on studies like Closenbach's.
Right. But it's also clear, isn't it, that we desperately need more high-quality, well-controlled studies to definitively nail down its role, especially in the crucial acute phase right after a stroke happens.
Absolutely. The potential is there, but the conclusive evidence, particularly for early treatment, still needs to be established through rigorous research.
Exactly. So this deep dive has hopefully given you, our listener, a comprehensive overview based on these sources, highlighting both the potential benefits we've seen reported and the existing controversies and unanswered questions.
Hopefully, you can now approach information about stroke treatments, including HBO, with a more informed and nuanced perspective.
And that leads us, I think, to a final thought-provoking question for you to consider. Given the ongoing research, the mechanistic rationale, and the clinical evidence we've discussed today, both positive and inconclusive, what do you think the future role of hyperbaric oxygen therapy might realistically be in the broader landscape of stroke care?
Definitely something to mull over. It's a fascinating area with potential yet to be fully unlocked.